Welcome to the Society for Academic Emergency Medicine's Upper Extremity Nerve Block video series. This is the first of two parts, covering brachial plexus nerve blocks. Part 2 will cover peripheral nerve blocks of the upper extremity. Let's begin with a case. A 64-year-old man is brought to the emergency department by ambulance after a fall down a flight of stairs. He has significant COPD and requires supplemental oxygen at home. His x-ray shows an anterior shoulder dislocation. This patient's underlying respiratory disease makes procedural sedation riskier. Let's consider our nerve block options. We will evaluate 4 choices. An interscalene block of the brachial plexus is one option. The interscalene block targets the brachial plexus at the level of the proximal trunks, affecting C5, C6, and C7 predominantly. The inferior trunk is typically spared, which consists of C8 and T1. The area receiving analgesia will include the shoulder, as well as the radial aspects of the arm, forearm, and hand, which should work for this injury. The patient is positioned sitting at an angle of 45 degrees with a rolled towel behind their back, head turned away from the block site. The transducer is placed in a transverse orientation on the neck at the level of the cricoid cartilage. The carotid artery should be identified along with the jugular vein. You will then slide posteriorly over the sternocleidomastoid. This muscle tapers off over the anterior scalene muscle, and in between the anterior and middle scalene muscles, the typical stoplight appearance of the trunks will appear. The needle is then inserted posteriorly through the middle scalene muscle with the goal of depositing anesthetic in this potential space between the scalene muscles. 10 to 15 cc's of anesthetic is deposited in this location. This is a video of an interscalene block. So we'll see the needle coming in posteriorly through the middle scalene and approaching to dissect the potential space right there, a beautiful dissection of the space between the scalenes. One more time, we'll watch that. And anesthetic dissecting the potential space. The advantages of this block include the best analgesia and muscle relaxation of the entire shoulder joint. And as an added bonus, the arm can stay in a comfortable position. You don't need to abduct or rotate. This block does have some significant disadvantages though. There is essentially a 100% chance of causing phrenic nerve involvement and hemidiaphragmatic paralysis. In a patient with severe COPD, this is contraindicated and will cause respiratory distress. Another disadvantage is the needle site of entry. Its location in the neck produces anxiety for some patients. Finally, there is a risk of subarachnoid and epidural injection with this approach. Let's look next at the supraclavicular brachial plexus block. This block targets the trunks distally as they pass under the midpoint of the clavicle, lateral to the subclavian artery and above the first rib. This block is typically used to give analgesia to the arm, elbow, forearm, wrist, and hand. The medial arm will not be affected, but that's okay for this injury. This area of analgesia would potentially cover an anterior shoulder block. The patient again should be positioned partially sitting at an angle of 45 degrees with a rolled towel behind their back, head turned away from the block site. The transducer is placed in a transverse orientation, this time in the supraclavicular fossa in the midclavicular area. The probe needs to be tilted steeply caudally into the chest, almost at 90 degrees, until the first rib, subclavian artery, and brachial plexus are identified. The needle is then inserted laterally, first directed towards the lower trunk, where 10 cc's of anesthetic are deposited. You may feel a pop when penetrating the brachial plexus sheath here. Then the needle is withdrawn out into the skin and then redirected more superficially towards the upper trunks, where after another pop through the brachial plexus sheath, another 10 cc's of anesthetic are deposited. In this video, we see the needle approaching laterally towards the medial side. You see the subclavian artery and then the bright bundle lateral to it, and that's where anesthetic will be deposited for this block. The advantages of this block include, again, good analgesia and muscle relaxation of the shoulder and arm, a comfortable arm position, but now with a much more palatable needle entry site in the chest instead of in the neck. There are still substantial disadvantages, however. There is a 50% risk of hemidiaphragmatic paralysis, which will not be tolerated in this patient. There now is a small risk of vascular puncture because we're approaching near an artery. And we do bear some risk of pneumothorax since we'll be working above the first rib. This block also requires repositioning of the needle, which is 2 needle trajectories to follow. And you may require some supplemental block of the skin of the shoulder, depending on what injury exactly you're working on and what was the mechanism. For our third potential choice of nerve block, I've combined the infraclavicular and costoclavicular blocks since they are pretty closely related. The costoclavicular brachial plexus block targets the brachial plexus at the level of the cords, but before they split to array around the axillary artery, while they still lie lateral to the axillary artery. This block gives analgesia to the arm, elbow, wrist, forearm, and hand. The medial arm again will not be affected, but that shouldn't matter in this particular injury. The infraclavicular block targets the cords slightly distally to this as they begin to split around the axillary artery. They have identical areas of analgesia, which should address the patient's injury. For the costoclavicular block, the patient should be supine, head turned away from the side of the block with the arm abducted and the elbow flexed. The transducer is placed in a transverse orientation under the mid-clavicle, tilted slightly superior. You should be able to identify the axillary artery with the brachial plexus cords arranged laterally in a triangular shape, quite superficial compared to the infraclavicular block, under the subclavius muscle. The needle enters laterally, targeting the space between the lateral and posterior cords, where 15 to 20 cc's of anesthetic are deposited. For the infraclavicular block, the patient is in the same position as for the costoclavicular block. The transducer this time is placed in a sagittal orientation, below the clavicle and medial to the coracoid process. The cords of the brachial plexus now are seen arrayed around the axillary artery. The needle is inserted superiorly at a very steep angle, targeting the space between the lateral cord and the axillary artery, where 20 to 25 cc's of anesthetic are deposited. These two blocks share some advantages, first of which is that the arm can remain in a comfortable position. Secondly, the needle entry site is palatable, not located in the neck. And finally, that there's a single needle target, so there's no need to redirect the needle. They also share disadvantages though. Though anatomy charts will show this block covering the shoulder distribution, practically these blocks are used more often distal to the shoulder. There still remains some risk of phrenic nerve involvement, which would not be tolerable in this patient, as well as vascular injury and pneumothorax. And lastly, in the case of the infraclavicular block, the approach requires a steep needle trajectory, and that makes it challenging to keep good needle visualization throughout the block. Sharp listeners will remember that I promised 4 choices, and so this last choice, the shoulder block, must be the one that we're ultimately going to choose. The shoulder block is actually a peripheral nerve block and not a brachial plexus block, but I've grouped it with these blocks given its location and area of analgesia. It combines blocks of the suprascapular and axillary peripheral nerves to give analgesia to the shoulder joint. For this block, the patient is positioned sitting upright, arm adducted, with a roll behind the back or legs over the side of the bed. We'll begin with the suprascapular nerve. The transducer is first placed in a coronal orientation over the distal half of the scapular spine. This requires a steep caudal tilt, essentially perpendicular to the ground. The target is the suprascapular nerve running along the floor of the supraspinatus fossa, under the supraspinatus muscle, and just lateral to the suprascapular artery. The needle enters medially at a steep angle, and then 10 cc's of anesthetic are deposited just medial to the neurovascular bundle. I will say that the artery is very small and sometimes not visualized on color Doppler in this location. This is a video showing the needle in situ in position for the suprascapular part of the block, and you can see how it's located right in that little V-shaped valley of the supraspinatus fossa. The patient remains in the same position for the axillary nerve portion. After withdrawing the needle from the suprascapular block, the transducer is moved to the second injection site. The transducer is placed in a sagittal orientation over the posterior aspect of the arm, in between the acromion and axillary folds. Here, the axillary nerve is identified running with the posterior circumflex humeral artery in the fascia between the deltoid and teres minor muscles. Approaching superiorly, the needle travels through the deltoid muscle to deposit 10 cc's of anesthetic just adjacent to the neurovascular bundle. The shoulder block has some fantastic advantages for this patient in particular. The first is that since it's a peripheral nerve block, there's no risk of diaphragmatic paralysis. Secondly, we have no risk of pneumothorax. Third, Again, the arm can stay in a comfortable position. And lastly, the needle entry site is very well tolerated by most patients. While there are some disadvantages, they are manageable. We recognize that this will give analgesia to the shoulder joint only, but for our purposes, that should be sufficient. The main drawback is that it requires 2 blocks. On balance, I would say, though, this block has the best risk-benefit profile for this particular patient, and so this would be my choice in this particular injury pattern. Let's take what we know about brachial plexus blocks and let's apply them to a new case. So let's say a 23-year-old man is brought to your emergency department by ambulance after he was hit by a motor vehicle and thrown from his motorcycle. He has suffered multiple injuries, the distal radius and ulnar fracture dislocation shown here, as well as a right clavicle fracture and multiple rib fractures. The blocks we've learned about so far are not going to cut it for this multiple injury patient. The rib fractures put him at risk of respiratory compromise, so phrenic nerve involvement makes an interscaling block contraindicated. Our blocks about the clavicle, either above and below, also have some risk of diaphragmatic involvement, but more salient is the fact that because of the clavicle fracture, their anatomy will be distorted, making them inappropriate for this patient. This case gives us an opportunity to discuss the final brachial plexus block, the axillary brachial plexus block. Don't confuse this with the axillary nerve block we talked about before in the shoulder block part, because that was the peripheral axillary nerve. This axillary brachial plexus block is an approach to the brachial plexus at the terminal branches as they travel with the axillary artery in the brachial plexus sheath. By this point, the musculocutaneous nerve has already branched off laterally, so that means you have a second target and injection site. But this block will provide analgesia to the distal arm, the elbow, the forearm, and the hand. For this block, the patient needs to be supine, head turned away from the side of the block, with the arm adducted and the elbow flexed. The transducer is placed in a transverse orientation, perpendicular to the humerus, near the intersection of the pectoralis major and the biceps muscle insertion. In this location, the axillary artery may be identified, with most of the brachial plexus anterior and then the musculocutaneous nerve running laterally and separately. Approaching laterally, 3 injections are needed. The first target is below the axillary artery, where 8 cc's are injected. Withdrawing the needle and adjusting to a more superficial approach, the next target is the anterior-most part of the brachial plexus sheath, where an additional 8 cc's of anesthetic are deposited. Finally, the last target is the solitary musculocutaneous nerve, where the final 4 cc's of anesthetic are injected. This block avoids the risk of diaphragmatic paralysis and pneumothorax, and the injection site is normally tolerated pretty well. This block is a common choice for surgical anesthesia below the elbow. The drawbacks include risk of vascular puncture, the necessity of shoulder abduction, which can be difficult in trauma patients, and the fact that it requires 3 targets, which is a hassle. In this specific case, though, this is the only brachial plexus block that's really viable. This concludes the video on brachial plexus blocks, and in part 2, we'll tackle upper extremity peripheral nerve blocks. Thanks for your attention.